listening to the Pharmacy Podcast Network.
Hello, and welcome to PTCE's Pharmacy Connect, a podcast focused on continuing education created by pharmacists for pharmacists. PTCE is the leader in pharmacy and managed care education. In these episodes, listeners will be presented with the most recent clinical updates and strategies for implementing into practice. And now, here's our host and founder of the Pharmacy Podcast Network, Todd Urey.
I'm excited to welcome back our listeners to the PTCE Pharmacy Connect podcast. These have been so valuable to our listeners, and pharmacists have commented back to us through LinkedIn, through Instagram, through Twitter, and different social media platforms that they like and enjoy listening to educational episodes developed by pharmacists for pharmacists. And today is no different. We have two amazing people accessible to our PTCE Pharmacy Connect listeners talking about treatment advances in atopic dermatitis with JAK inhibitors, updates for pharmacists. We have Dr. Jamie McConaha here and Dennis Williams. Jamie, welcome to the PTCE Pharmacy Connect.
Thank you. Happy to be here.
Jamie, tell our listeners a little bit about yourself and your role as a pharmacist and as an educator.
Absolutely. So as you mentioned, my name is Jamie McConaha. I am an associate professor of pharmacy practice at Duquesne University School of Pharmacy, which is located in Pittsburgh, Pennsylvania. I am a clinical pharmacist here, so I maintain a practice site within a primary care physician group that is local to Pittsburgh. At that practice site, I see patients through a collaborative practice agreement with our physicians for a variety of ambulatory care disease states. And with regards to today's podcast, I do have a very strong interest in all things dermatology. During my fellowship program, that was the focus of my research project, and I developed and teach a dermatology elective here at Duquesne to our students.
Excellent. Thank you so much for that opening. Dennis, we want to hear a little bit about you and wanted to welcome you to the PTCE Pharmacy Connect as well.
Thanks, Todd. I appreciate the opportunity to speak to the group on this important topic. I'm Dennis Williams. I'm a faculty member at the UNC Eshelman School of Pharmacy. My primary focus areas in teaching, research, and practice have been in pulmonary diseases, infectious diseases, and immunology in general. And I think this is a very important topic, basically because of how prevalent the problem is. I spend some of my time in practice, a lot of time in the classroom, and then also investigating some of the newer treatments in pharmacotherapies.
Excellent, and thank you for that. So we have talked about JAK inhibitors on other episodes, but this is a special episode. Jamie, you're going to be taking over and leading us into this content, and we're going to review that atopic dermatitis as well as the efficacy and safety data for topical JAK inhibitors that are approved and in development. We like that. We like that mixture of subject matter expertise. So with that, Jamie, I'm turning this podcast over to you.
Thanks, Todd. So I'm so excited to get into this topic, such an important and relevant topic. So Dennis, let's just start with the background. Can you start telling us a little bit about atopic dermatitis and really the significance of this disease state?
Yes, absolutely. So atopic dermatitis is very generally described as a skin condition that's associated with a hypersensitivity response. And as most pharmacists know, there are a variety of hypersensitivity responses. This one is referred to as a type 1 hypersensitivity response that we'll talk about a bit more what that means. And the reason that I think that atopic dermatitis is so important is is that the impact that it has is largely driven by the prevalence. How many patients, how many people suffer from this disorder? And there are a variety of estimates, and I think these estimates are difficult sometimes to gather because like other atopic diseases, a lot of it may be self-managed, but the best data that I know of is that 15% of children and up to 10% of adults suffer from this. And like other conditions, there's a spectrum of severity. But in my experience, maybe more than half of people have mild disease, but that means that 40% of people have moderate to severe disease. And the impact of this disease really across the range of severity is pretty significant because it affects people physically, it affects people psychologically, and in a broader way, their overall quality of life. I do want to mention here, just so the audience is familiar with it, is that atopic dermatitis is often described as eczema. And the way I think of it is that eczema is a subgroup of atopic dermatitis, and atopic dermatitis actually represents a broader spectrum. I want to make a couple of comments about what we know about the underlying cause here. I think it's important. So as you can tell from the name itself, that there's an atopic predisposition. And what that means is that a person's immune system has a particular response that predisposes them to allergies. And it's not only atopic dermatitis, it also includes asthma and allergic rhinitis. And so if people want to get deeper into that, and the immunologic response is related to a Th2 lymphocyte response that predisposes patients to this. The other very core thing that we know about this condition is that a lot of it is related to a genetic defect in a protein, and that protein is called filaggrin, and that protein is very important in our skin because it's responsible for the structural support of our skin, and it helps to maintain the integrity of the skin. So with this atopic predisposition and with this problem with this protein, what patients experience is a significant loss of moisture from the skin, which really leads to a lot of the things that patients actually experience.
Thanks, Dennis. That was a great introduction to atopic dermatitis. And I love how you touched on the atopic triad, because I think that's something that as pharmacists, we can recognize patients who may be at greater risk for atopic dermatitis if they have some of those other disease states. And you also had mentioned, really the burden of this disease state. So I know when I teach my classes at Duquesne and we talk about derm conditions, I always say, these may not be the disease states that are necessarily associated with mortality, but the psychological consequences that they can have on patients are very significant, which is, really why it's so important that as pharmacists, we can help with a lot of these newer medications to alleviate their symptoms. And that really brings me to the next thing I think is important as we're discussing this background of the disease state, is can you describe to the listeners how atopic dermatitis clinically presents, or what type of symptoms we see in patients?
What we encounter in patients are a variety of symptoms, and again, some very mild to the more severe, but, the general things that we see in patients is very characteristic to have a rash. And that, as I mentioned before, that's where the eczema description comes from. A very prominent symptom that patients have that you will see later when we talk about some of the clinical data is itching. Pruritus is such a common symptom in this condition. And then that results in other things like erythema, scaling of the skin, which can result in burning. And those kinds of things can end up resulting in the development of blistering or fissures in the skin. And that kind of leads to one of the complications of atopic dermatitis, which is secondary skin infections, which is a real problem, especially in people with moderate to severe disease. And it really creates a lot of problems. And this chronic irritation and chronic inflammation ends up changing the features of the skin. And so a lot of patients with atopic dermatitis end up with rough and inflamed skin. And then the final thing we see in people that, are going without therapy is thickening of the skin. And that's referred to as lichenification. And that's a really bothersome sign and symptom for patients that we want to avoid through effective therapies.
Yes, absolutely. It's definitely a devastating disease state, with regard to the symptoms that these patients are experiencing. You mentioned near the beginning about the prevalence of this, particularly in younger patient populations, and that itching and scratching and, the impact it can have on children or even adults, quality of sleep. And I know everything is worse when someone is sleep deprived. So, it's definitely a very impactful disease state. And of course, we're going to be talking today about some of our newer and emerging agents for atopic dermatitis. But before we get there, what do you think are some of the challenges with the current therapies that are available?
Well, of course, a lot of patients are maybe not appropriately diagnosed. So maybe we're missing a lot where as pharmacists, we could be offering a lot of benefit because we have this spectrum of severity. Not all the therapies are effective for everyone. And with some therapies, we see that there's a delay in response. And of course, those are the kind of things that will make patients frustrated and potentially affect adherence to therapy. And then, frankly, with some of the baseline therapies in this area, there's some inconvenience of use that make patients be less adherent. And then finally, because we know that that patients with moderate to severe atopic dermatitis may not respond to some of those foundational kinds of therapies, they may require other options. And I think there's good news and bad news in that area, and that there have been a lot of advances in that area that offer patients more opportunities.
Yes, I agree. Absolutely. So what do you think are some just general recommendations that pharmacists should make for patients with atopic dermatitis?
Well, Jamie, I think this is really important because when you read clinical guidelines and other recommendations in this area, the foundational therapies are so important across the spectrum, even when we get to more targeted therapies that can really help some of our patients. And so in this area, foundational therapy is moisturizer. There are moisturizer agents. And I think there's really a lot that pharmacists can do in this area in terms of making recommendations to patients. Obviously, moisturizers add moisture to the skin. Unfortunately, there are a few different ways to do that. The things we think about are emollients, humectants, and occlusives. And there are advantages and disadvantages to each of these in terms of both how they work, but also in terms of how acceptable they are to patients, and often, predict why patients maybe need to be thinking about other additional therapies in order to control their condition.
Yes. And I think patients probably when they go into the grocery store, go into the pharmacy, they see aisles and aisles of these moisturizers or these topical agents. And a lot of times they can be totally lost on what to select. And, as you pointed out, I really think that baseline or foundational treatment with the moisturizer is absolutely crucial to the treatment of atopic dermatitis. Eventually, continuing that as we continue to add on treatments. So, obviously we're getting to some of our newer and emerging agents that we keep alluding to. So what are some advances that have been made in recent years for managing moderate to severe atopic dermatitis?
Yeah, good to focus on that. So, beyond moisturizer therapy, what kind of things do we have for this particular group of patients? I'd start off by saying that, there are a variety of what I would call traditional immunosuppressive therapies, corticosteroids and other things, other immunologic agents like calcineurin inhibitors, and then in recent years, even phosphodiesterase inhibitors have become an important therapy. What's exciting to me is over the past few years is the identification of a variety of targets that can be treated with biologic therapies. And so there are really a handful of biologic targets among the cytokines. And then in addition to that, we have the Janus kinase inhibitors, which have been, I think, a big move forward for this condition.
Yes, so that is what I'm very excited to talk about today. And of course, the topic of this podcast. So can you tell the listeners what JAK inhibitors or Janus kinase inhibitors are currently available for atopic dermatitis, and maybe a little bit about their mechanism of action?
So Janus kinase is a protein. Obviously, it's an enzyme, and it acts. It functions under the control of some of the cytokines that are involved in this condition, and its effect is really to change that immunologic response. And it actually happens very specifically in the cell in terms of transcription factors that work in the nucleus of the cell, and they change the way this inflammatory response occurs. And I feel like that the pharmacy audience knows about JAK inhibitors because they've seen those in a variety of other immunologic conditions, including malignancy, rheumatoid arthritis, and other kinds of things. So I think they're familiar with that, and maybe that helps appreciate how they might be helpful in this condition as well. What we know about JAK inhibitors in this condition is, I think it's important to explore, maybe the different dosage forms and the things that are most helpful, but there are oral and topical forms of JAK inhibitors. And, a few examples of those are abrocitinib, upadacitinib, and baricitinib, and all of those are oral JAK inhibitors, useful and proven to be helpful in patients with atopic dermatitis. Ruxolitinib is also a JAK inhibitor. That's the one available topical form that we have now to treat atopic dermatitis.
Yes, and I love how they're available, as you mentioned, in both formulations. We have our JAK inhibitors orally and topically to really give patients different treatment options that may fit best into their lifestyle. So when we are comparing these agents, the ones that you just went over, I'm sure as pharmacists and, any prescriber would really be interested in the clinical evidence, particularly focusing on the effectiveness and safety of these agents. And I know that there are numerous scales and different types of measures that are used not only in clinical studies, but also in practice. And I was hoping you could review those as well for our listeners, what we use to gauge how well these agents are working.
Yeah, good idea, Jamie. I think when we think about a condition like atopic dermatitis that it affects people in a lot of different ways, I think having scales that are, somewhat objective are really helpful in terms of evaluating response and being able to report those results. And so fortunately, in this condition, we have validated instruments, and they look at a variety of aspects of of this condition. I want to just name a few of them that I'm familiar with, that I see in clinical trials, and that are also used in clinical practice to evaluate the benefit patients are getting. And so one is called the itch numerical rating scale, which should make sense to people, and that's rated numerically from 0 to 10. Another one is an investigator global assessment treatment success. And I want to make a comment about that in just a moment. And the third common one that I see a lot is the eczema area and severity index score. And all of these are numerically rated in terms of, how is a patient today? How is a patient, after receiving some therapy? And the other thing that I really like about these validated tools is that they really take in information both from the patient who's being affected as well as the clinician that's seeing the patient. So what have we seen with the results, specifically with JAK inhibitors using these different scales? And so the results are pretty good across the board. And actually, when I look at the data, the results are pretty good, whether we're talking about an oral therapy, a systemic therapy versus a topical therapy. So with the JAK inhibitors, if we look at the literature, the results have been impressive, reporting things like anywhere from, when I look at things from like 65 to 75% improvement in those various signs and symptoms of atopic dermatitis. And the other thing that I think is really very promising in that area is that those improvements happen pretty quickly. That response can be seen as soon as after 2 to 4 weeks of therapy. And so that certainly helps with adherence. Patients are using these therapies and they're seeing some of the benefit right away. I'll mention a couple of the things that I've seen specifically about agents. Pathophysiology had a double improvement in EASI scores. Abrocitinib had a 75% improvement, and the investigator score was actually pretty good. And ruxolitinib, the results showed that the EASI was improved by 71.6% compared to placebo, and that was actually more than 4 times the placebo improvement. So with these agents, with any agents, obviously we have to think a little bit about how well they're tolerated. So I just want to mention briefly that with the JAK inhibitors, the most common side effects that have been reported have been related to the GI tract, and then some patients have reported headache. But in general, these agents have been very well tolerated. And finally, JAK inhibitors in general, regardless of what they're used for, do have a black box warning that address a few different issues, including the risk of infection, malignancy, and some cardiovascular complications and hematologic complications that pharmacists should be aware of and review again, although these agents are generally well tolerated.
Thanks. So that was a very thorough discussion of our JAK inhibitors, the safety and the efficacy. And I really like how you pointed out when you started the beginning of this section with the different scales that we use to measure these, really describing the significant improvement that we see in our patients with atopic dermatitis with the JAK inhibitors. So, in these studies comparing these agents to placebo, you gave us a lot of great statistics about the improvement and how quickly that occurs. So these are, again, very efficacious agents for our patients. And I did want to point out as well, the EASI that you had mentioned, that scale, the Eczema Area and Severity Index. There are, I'm sure our listeners are familiar, and as pharmacists, we maybe don't use this so much ourselves to actually score patients, but rather read the results of these. But there are different versions of that scale depending on the age of our patient as well. But in these studies with our particular JAK inhibitors, you're right, we've seen great improvements, to a fairly fast rate, and with minimal adverse effects really compared to placebo, just like you went over. So there was a wonderful, thorough review of everything with those. So now that we've talked about some of these emerging treatments, I think it's important to talk about our role as pharmacists. So what do you think are some considerations that pharmacists should take into account when counseling patients about the use of the JAK inhibitors for atopic dermatitis?
Yes, a lot of information, I think, to give to patients, which can be very useful. And one is just very practical things about what they should expect when using these agents. But in some cases, with all these therapies, we're talking sometimes about injectable therapies, and we're talking about topical therapies. So there are some specific things that we can talk to patients about. And they should kind of fit into two buckets, talking to them about when they could expect a response. And we mentioned before with these agents, maybe within 2 to 4 weeks. And we should talk to them about some of the safety concerns, some side effects that they might experience, even though those don't happen very often. I think in the bigger scheme, talking to patients about the benefit of topical therapies and how to get most benefit from them. Ruxolitinib, for instance, it's recommended that you could really treat up to 20% of the body surface area, which is a pretty big area with continued safety. And with some of the therapies, there's the ability to titrate it based on the response the patients are getting, as well as to kind of step back a little bit if the patient's condition is well controlled. And then something that I see that's been emerging in topical therapies, which I think is a real advance, is how to measure the medication. And so there's not necessarily a new, but an emerging concept that is talk about fingertip units. That gives the patient some idea about how much medicine to measure out of a topical therapy to apply to a specific area of the body. So, and I think those are the biggest practical things that I see.
Yes, super important. And especially with counseling patients about the topical applications, because we mentioned earlier about the importance of including moisturizers. And you mentioned with these pharmacologic agents, the fingertip unit measurements, and just, making sure they're using an appropriate amount and being adherent to the medication, because we all know, obviously, if they're not going to use it, it's not going to work or help anyone. So where do you think then that these JAK inhibitors fall into practice? Or what do you think really is their overall benefit for patients with atopic dermatitis?
We've already identified the fact that 40% of patients with atopic dermatitis have moderate to severe disease. And so they're not going to be effectively managed with just moisturizer therapy. And so we need to be thinking about other agents. I'm not sure how much I emphasized this before, but one thing that I really like about JAK inhibitors is that they're downstream. A lot of the cytokine therapies that we have for this and other conditions are more upstream. And, one thing I think about a lot with upstream therapies is that they could have impacts in other areas, kind of innocent bystander effects, although I'm not sure that we see that necessarily in that area. But JAK inhibitors are downstream, and so we're really targeting the problem, especially in atopic dermatitis. And so I think as an entire class, it's a significant advance.
Absolutely. So I just have one final question, and that would be, what would you say is the single most important takeaway for our pharmacists listening in?
Well, Jamie, as you mentioned, we talked earlier about the impact of this condition. And again, to me, the impact is also often based on how much does it impact the individual patient, how prominent is it, and how many patients with atopic dermatitis are pharmacists going to see, and how do they understand how significantly it affects somebody, and understanding that, and having some empathy towards that, and trying to think about the best therapies for patients is a good concept. And then on top of that, thinking about if a patient's not responding to the therapy that they're on, what other options, are available that maybe they could talk to their prescriber about. And then finally, because it's a topical therapy, being pretty specific in counseling about the best ways to apply that. Those would be the things that if on the front line as a pharmacist, I would think about.
Thank you.
Thanks for tuning in to the PTCE Pharmacy Connect podcast. Your feedback is important to us. Please share with us your thoughts on this episode and other topics you'd like to learn about. Go to pharmacytimes.org/contact and send us a message.